Welcome to Dr. Balga's podcast for the Curious Doc. Today is Feb 25th, 2026. This video is on a JAMA article published online today titled Worldwide Radiation Dose in Coronary Artery Disease Diagnostic Imaging by the INCAPS 4 Investigators Group. Coronary artery disease is the leading global cause of mortality. Expansion of nuclear cardiology and coronary computed tomography angiography (CCTA) increases ionizing radiation exposure. The guideline benchmark is a median effective dose equal to or less than 9 millisieverts. The INCAPS 4 investigators did a cross-sectional study. The study cohort comprised of 19,302 adults from 742 centers in 101 countries from October to December 2023. The modalities they reviewed include SPECT or single photon emission computed tomography, PET positron emission tomography, coronary computed tomography angiography (CCTA), and coronary artery calcium scoring. The primary outcome was the effective radiation dose in millisieverts. Median age of the study cohort 63 years, about 44% were women. Linear mixed effect regression with clustering by center and country was used as a statistics technique. What they find? The median effective dose for coronary artery calcium scoring was only 1.2 millisieverts. For PET it was 2 millisieverts. For the SPECT study 6.5 millisieverts. For the computed coronary CT angiography, it was 7.4 millisieverts. However, the dose of less than equal to or 9 millisieverts was achieved only for 81% for nuclear studies and only 56% for computed coronary CT angiography. The p-value is 0.001. In Africa, computed coronary CT angiography, the median dose was 25.2 millisieverts, versus Western Europe, which was 4.6 millisieverts, a greater than 500% difference. In lower and middle income countries, 20% had higher nuclear dose, 96% higher for computed coronary CT angiography, p-value 0.001, less than 0.001. The newer scanner technology significantly reduced the dose from p-value less than 0.001. The limitations of the study was a single week of sampling, possible selection bias, image quality was not assessed, and the effective dose is a model-based estimate. The key takeaway of the study: there is marked global variation in the radiation received by the patient. There is an urgent need for training. There is an urgent need for protocol standardization and equipment modernization, especially for coronary computed tomography angiography, that is coronary CT angiography in low-income regions. What is the model risk for 10 to 20 millisieverts of radiation? Modeling using linear no-threshold framework and BER7 risk coefficients for an average adults, 10 millisieverts of radiation is equivalent to 0.05 excess lifetime cancer risk, that's 1 in 2,000. With 20 millisieverts, about 0.1% excess lifetime cancer risk, that's 1 in 1,000. Important modifiers: younger patients, higher risk, there's longer remaining lifespan, and higher tissue sensitivity. Older patients, substantially lower risk. Women have slightly higher risk than men at the same dose. The cumulative exposure is additive. To place this in perspective, baseline lifetime cancer risk is about 40%. A 20 millisievert exposure increases the risk to 40.1%. Individually small, but population level meaningful. Clinical pulse, coronary artery calcium scoring, and PET deliver lowest radiation doses. coronary CT angiography dose distribution is highly skewed. Large minority receive very high doses. Center-level practice patterns explain most dose variation. Newer scanners substantially reduce radiation. Dose benchmarking should become a quality metric in cardiac imaging labs. These are some eponyms related to the study. Hit pause and read at your leisure. Podcast brought to you by masterbedfacts.com. This podcast is for physicians and healthcare providers. If you enjoyed this video, please like, subscribe, and forward to your friends.